Hello and welcome to another Junto Health Dealflow event. Today we're hosting Midas Healthcare Solutions, who are referred to us by SVG member Dave Debe of 50 Ventures. SVG is an investment club for digital health. We were created to help accelerate strategic venture investment into today's best digital health solutions. So one way we do this is by hosting really crisp, focused, efficient deal flow events in which we put curated, vetted founders in front of name brand strategic investors like yourselves. So these events are private, they're designed to be intimate discussions. We really want to cut through the noise of the digital health ecosystem and help convey clear information to both sides of the table so that you could then take those conversations and run with it internally. So we hope that these conversations lead to funding, but we know that there's no pressure either way. So today we'll be hearing from the co-founders of Midas Healthcare Solutions, Michael LaFauci, CEO, Jeffrey Wall, President, and John Opinski, COO. After about 15 minutes of a facilitated presentation where they'll show us their company overview, the product, and where they are now, we then want to open it up for any questions and comments from the audience. So as a reminder, you can find their emails in the chat, and you can leave your questions in the chat, or you can hit the button, Ask a Question, which is at the bottom of your screen. To make this as conversational as possible, we will invite folks onto the screen so that you can ask your questions directly. How does that sound? Gentlemen, you feeling all ready?
Yeah, we're ready.
Thanks, great. Man. So by way of introduction, I'm going to hand them the virtual mic, starting with Michael, to give us a brief background of your professional experience. Over to you.
Terrific. Thank you so much, and welcome to our call. So my background, originally, I'm a pharmacist with 20 plus years of experience within hospital, corporate, worked for GlaxoSmithKline at some points in my career, retail and academically, an adjunct professor at St. John's University School of Pharmacy. Left my career back in the early 2000s, became an entrepreneur, started focusing on building companies organically in the technology and software sectors, and they were centered around remote ordering processes, electronic prescribing, and my last company, a successful exit, was a medical device company. Sold it off to a publicly traded company called Cooper Surgical. What we're doing here today is Midas is taking the old paradigm of accountability around medications post-dispensing and providing a really smart platform to address diversion and addiction in our healthcare institutions as well as our homes. And we're excited to talk about how we're going to, show you our technology and what the capabilities are. But I'd like to just toss it over to my team and my co-founders, Jeff Wall and Jonathan Pitsky. So, Jeff.
Thank you very much, Michael, Doug, and welcome to our guests. I'm Jeff Wall. For 37 years, I have had a national healthcare risk management and patient safety law practice. I have a particular area of interest and expertise, which is operating room safety, even more specifically, anesthesia risk management and patient safety. I write a lot about that. I teach at medical schools, bioethics programs, healthcare communications programs, law schools, including some SVG member hospitals. I lecture at national and international medical conferences. My next two gigs are one to kick off the academic year at Harvard to speak about drug diversion at Brigham and Women's Hospital Quality and Safety Initiative, and also the International Health Facility Diversion Association. I ran the medical advisory board of a Silicon Valley healthcare technology company called In Vivo Data, which created patient-centric data capture devices on Palm Pilots. And we had a successful exit. So I'm going to toss it to our COO, John Opinski, for a brief bio, and then he will be your tour guide through our presentation today. Jono.
Great. Thanks, Jeff. Nice to be with all of you today. John Opinski. My background started in digital image database design. So real technology background, founded a company in the mid-90s, kind of grew through the internet bubble, sold that in 2000. And after that exit, met Michael, got into the concession ordering business with him that he briefly touched on. And then after that, when Michael got into medical devices, I went into consumer products, built a company that wound up distributing oral care, personal care products in 20 different countries, sold that in 2017, just when Mike and Jeff were getting this started. So my operational and product development lift in my really a great addition to Midas. So with that, I'm going to share my screen, jump right in. Hope to get this done in about 15 minutes or so that we can open this up to Q&A and some dialogue. So here we go. Great. So to start off, I want to just say that, Midas was really founded because Michael, in some consulting with BD Pyxis, realized that there was this major problem with fentanyl patches and what happens when those patches come off, how dangerous they are, how diverted they are. Diversion is when someone's taking something and doing something they're not supposed to with it. And then started to realize how much this leads into, the dangers of addiction, abuse by caregivers in hospitals. And so I want to share a little bit of that with you. When we looked at fentanyl, we realized that the problem wasn't about fentanyl specifically, or pills specifically, or injectables specifically, but the whole process of wasting medication in an institution was a big component of addiction and abuse. So to share that, I want to just show you this slide. These are automated dispensing machines. There's a couple of 100,000 of them from BD Pyxis and Omnicell, primarily hospitals and medical facilities all over the United States. And what they do is a really great job at safety and security when medication is dispensed. So they use this amazing technology. You have to sign in biometrically. It's going to give you a specific dose of medication, but that stop dose is not always what the patient needs. And so they often have to throw away part of the dose, right? Half a pill or a cc out of a syringe. And this is the technology that we find when it comes to wasting. There is none, right? It's incredibly archaic. So you have things like sinks and toilet bowls, sharps containers, and these items that you see here on the right side, they do a good job of segregating waste. But these devices do not prove that what you told that ADM you were going to waste actually made its way into the receptacle. In fact, when you waste a controlled substance, you have to stop what you're doing, go find another authorized healthcare provider to witness that wasting episode. It's a tremendous deterrent to what they're trying to do, which is take care of their patients, right? So this gap in this safety and accountability is a target for diversion, right? This leftover medication. And it's where a lot of that medication gets diverted and abused. Now, here's the hidden piece of this, right? It costs the hospital and medical industry billions of dollars when this diversion occurs. And there are over 300,000 healthcare workers right now today in the US who are diverting or abusing. You can see here some of these bullets talk about why it costs billions of dollars. Everything from DEA fines, lawsuits when patients are harmed, that's when it gets really bad. But staff has to be reallocated, fired and rehired, management has to get involved, and the institutions that we speak to have national diversion teams deployed to try to mitigate this every step of the way, including software and other methodologies. You could see here we're talking about, over 100 million doses of medication. Diversion is on the rise, and hospitals are desperate to solve this. It doesn't discriminate. So from Mass General, Emory, University of Michigan, the VA, and you can speak to hospitals, institutions. This audience certainly knows this very, very well, that the consequences are everywhere. And we took a look at the industry. It's not just hospitals, but you get into long-term care, private practice, pharmacy. Our solutions can get a better opportunity to safely waste in all of these environments. So we're here to change this. And the way that we're going to do this is with intelligent medication disposal. And so there's a bunch of things to look at on this slide. But in a sense, what if we added technology to the wasting process the same way that the automated dispensing machines added technology to dispensing, many, many years ago? So what I want to do is very quickly take you through a wasting session. Just going to run you through a few slides very quickly to show you what would happen in the moment that somebody walked up to a Midas system, which is tablet and mobile driven, to do a wasting occurrence, right? So when they come up to our tablet or mobile system, they're going to log in. It's biometric, so they're going to log in with facial recognition. They can log two people in at the same time, which is important because, like I said, the rules now say that you need a witness if you're going to be wasting a controlled substance. I do want to pay attention to this image here because you can get a remote witness. So you don't have to go bother somebody to come next to you with this system. You can remotely log in and you could watch the wasting process on the system. Once they touch the screen, they'll be presented with patients coming from that automated dispensing machine, right? Because we're going to integrate with those solutions. They have the patients that they're taking care of at that moment, and they're going to click on one of those patients. And when they do, they're going to see the medications that have been pulled from the ADM during that shift for those patients, because those are the medications now that may need to be wasted. So we're going to use the morphine in this particular example that was pulled at a given time, but we know that they pulled an amount that was more than what the patient needed. So now they've got to enter the amount of morphine that has to be wasted. And then with just a couple of clicks, the system is going to also ask them for the reason that they're wasting, right? It was an unused general waste, and they're going to hit that button. When they're done with that, the other camera on the tablet, right, is going to be watching their hands, and it's going to also be watching their face. So we have dual camera, 4K, high res, high speed, and it's going to tell them to dose that medication, draw it up in the syringe, everything they have to do with it. And then it's going to take them through several steps. For time's sake, I'm not going to take you through them, but it's going to be watching them waste the excess medication. That's whether they're squirting it out of a syringe, or whether they're splitting a pill, or they're getting rid of a fentanyl patch, etc. And eventually, they're going to deposit the excess medication into the wasting port, which is here. And they're going to then, in the case of this one, they would put that syringe in this sharps container, also covered by the camera, so there's no gap in the wasting process. One of the things that I really want to point out right now is it's getting wasted into a solution called NarcX. We're working with them because they have a solution that will make that medication non-retrievable, and now the medical waste can go out with the regular trash, right? Right now, they've got to work with collections, get it to a reverse distributor. The Stericycles of the world have to come pick it up, but our solution system is able to neutralize that on site. And this does work in all of these different kinds of environments that you see here. When they go to do that wasting process, there's another little hidden feature of the software. It's randomly going to ask for a sample, right? Because sometimes we might want pharmacy to assay what they're actually wasting. So it'll pause, it'll give them an opportunity to put that sample into a test vial, lock it away in a drawer, and then pharmacy can come up and look at that. You can do this randomly, or you can assign the system to look at specific nurses. Maybe it's a new trainee, maybe it's somebody that's suspect, to assay what they're collecting. And then when that's done, it's going to give a summary of what happened, who the witnesses were, your captured waste, and the process is finished. Now, I walk through this slowly, but there are really just 5 screens. It's actually faster than what they do now, because now they have to go to that ADM, find that witness, and then they have to go over to that wasting receptacle. So this is the overview of the system itself. I want to talk about some of the value benefits to a hospital. This is way too crowded of a slide for my liking, but there's just so many value propositions for the system. And I'm just going to call your attention to the left column, from nursing, pharmacy, environmental services, and on down to, of course, patients who we're really trying to help the most, and empower the healers. All of these bullet points on this page are current pain points with the current wasting process and the current chance for diversion. All of them are either reduced or completely eliminated, with the Midas system. To get into a little bit of the business of this, we are talking to lots of different hospitals. We are, I'll talk a little bit about what stage we're at in a minute, but we've got a specific use case with Rainbow Babies and Children's University Hospital in Cleveland. And this is an example. 20 of these systems could handle over 200 beds. And when you look at the way that we're going to be deploying these, about $175 a month on a 3-year commitment. There are maintenance and supplies like that NarcX and the vials for assay, but it's a very inexpensive cost, you see less than a full-time employee, they can be covering over 200 beds. And the daily cost per system and the hourly cost per system, it really makes this a no-brainer, especially when you compare it to the cost of a lot of the systems that they put together and how many people have to try to assess potential diversion incidents after they've already happened, right? This is all designed to be preemptive and upstream. So that's a use case example. This is a picture, I'm not going to get into this now, but we've got a future technology, which is a kiosk-based system, obviously more expensive to deploy, bigger lift for Midas, but there are some hospitals that can use this system in select locations. Just wanted to tease you with it, but also give you an idea that even a use case of this system down the road, it's a little bit more expensive to cover a similar amount of beds, but very beneficial, to the hospital systems. When we built this, we didn't do it in a bubble. So we went to nurses, pharmacists, anesthesiologists, did days and days of user insights and user testing to help us with this from a user point of view. On the right side, I'm not going to go through all of them, but then we have very high level quotes from everyone from, CEOs, heads of pharmacy, heads of diversion in different major hospital systems. And also want to reiterate that, we are connecting into the Omnicells, the Pyxis of the world. We have great relationships with them already and with the medical record systems in a hospital. We're going to be generating quite a bit of data around wasting. That data is very valuable in the hospital setting, specific to the individual patients. And in an aggregate setting, it's very, very valuable to government. We've spoken to a lot of government stakeholders already, from DEA to the bipartisan opioid task force, and we've got a lot to talk about with data. For the sake of this presentation, though, I'm going to keep that part really brief. From a systems point of view, we are currently in development. We're really at the precipice right now of going from our software spec to our build right now. So we are looking with strategic investors and people who can help us to collaborate on the development. We'll talk a little bit more about that runway in a minute. But we've made great inroads with major medical institutions. So HCA really being the first one to mention. We have a pilot program that's been approved with them in Tampa, St. Pete area. The rest of the folks on this page, we are in 3rd, 4th, 5th level talks, everyone from the C-level down to their directors of pharmacy, and looking to secure a few pilots with these folks soon. Quick, brief little story on our amazing advisory board. You can see from government, the two governors over here on the left, Governor Ridge and Governor Christie, Marla Weston, who ran the ANA, Carmen Catazon and Tom Medigan, who have incredible pedigree in the pharmaceutical world, and Charlie Aludo, who ran Stericycle, right? $9 billion company. He's really helping us to modernize all the automation in what it's like for this reverse distribution and waste. Toby Cosgrove ran the Cleveland Clinic. He's been instrumental. And Andrea and Bob really round out our board of directors. Nottingham Spurk is our development partner, and Wilson Sonsini are the folks that we started our corporate council with, but they really have handled now, I think we have about 14 patents, domestic and international, that are filed with them. And then through those people and other advisors, amazing relationships in government, corporate, healthcare, and professional organizations. So that's a little bit of background on company. I want to get into the business for the last few minutes and share this slide, which really shows that Midas is thinking a whole lot more than just this view system that you see on top. I'm not going to get into details today, but we have items that are already prototyped and filed from an IP point of view around fentanyl patches, injectables, medication in the hospital and the supply chain. On the retail side, because there are 400 million bottles of pills in our cabinets right now sitting there waiting to be properly disposed of, which these round out. But we are very focused now just on this view system. So we're not diluted in all these other opportunities. You can see that we've modeled those so that they start coming 2 years, 3 years, 4 years out. But the investment obviously is in the full ecosystem. So bringing it back just to the view system and to give you some color on where we are in fundraising and financials and the market size, we see a total addressable domestic market for this VIEW system. It's over 150,000 points of care, and it's kind of broken down this way. I want to call out pharmacy because, yes, there are institutional pharmacies in hospitals that need the help of Midas visual accountability, but we've started to talk to CVS, Walgreens, the reverse distributors, because pharmacies right now spend millions of dollars a year in the return process on expired medications, recalled medications, and they're shipping garbage basically back to reverse distribution centers and then back to the pharmaceutical companies themselves who want custody of their expired medication. Midas is starting to speak to them now about visually accounting for that waste on site in the pharmacies, in the back of the pharmacies, so that it can be diluted. I mean, it can be discarded and rendered non-retrievable in the Narcex and disposed of on site. The cost of money to get those returns, waiting for that float, and also moving all that stuff and paying everybody to move it is a huge waste. So that opens up a big market for us. And you can see a little bit about how we charge. I mentioned that before, a little different between healthcare institutions and pharmacies. And this is a very high level projection on how that would ramp. This is hospital only projection. So I've got to stress in our modeling, we have not started to expand the market for how many points of care this mobile can address. And it also doesn't include data sales and subscriptions because we have all these stakeholders that are interested in our data. A little bit more on that funding status. We are in great relationships with Omnicell and Pyxis, and they both have introduced us to people on their biz dev side because they see a great synergy in Midas and them doing things from not just interfacing the data, but also interfacing potential products in the future. We have signed letters of intent with strategic partners on everyone from the reverse distribution to also some of the systems that currently monitor diversion in hospitals. And then a little bit about our funding. There's a little bit more of this on the last slide. But we've raised $2.75 million to date. You see here $1 million in a Series C, $1.75 million in a current Series A. It's a $7.5 million total, but we only need between $1 million and $1.5 million to finish the software, get that deployed, and put that into work to get the traction that we're looking for in the industry with HCA and others. With a little bit more of that money, we can complete that kiosk version, and then the remainder of that money would go towards early development and engineering of those other products that we filed for and that are in our ecosystem. So to cap it off, this is a $7.5 million raise. You can see the pre-money valuation there, the 18-month runway, a little bit of what I described and what we're going to use those proceeds for. And then on the right side, you see a little bit more color around this VIEW mobile system. Most of the things that are on here I've already said. I just want to call out that this system kiosk you see here, it's about $1,000 or less for us to get that thing manufactured and deployed, per unit. And then you see that recurring revenue, what that looks like over those first 3 years with a chance of renewal. So hopefully that kind of took you through very quickly. Mike and Jeff, are standing by because if there's any questions or anything I missed to get a little bit more detailed on, especially on the medical process side, they're there to do that. But with that ready to, open it up for discussion.
Great. Thank you, Jono. Can you hear me okay?
Yes.
Great. All right. Jeff or Michael, do you want to add anything as we wait for any questions to come in? And just as an announcement for anyone who's listening, if you have a question, feel free to post it in this chat or in the Ask a Question box, which is at the bottom of your screen. And we can invite you on screen so you can go back and forth if you have any comments.
Yeah, so I'd like to add something. Thanks so much. And one of the points I want to add is that when you go back to the witnessing portion of what Jonathan was explaining before around a controlled drug substance and the wasting process, is that Jonathan was speaking about how you can have a remote witness. What we envision for the company moving forward is, what would it be like if this would become the virtual witness? So there'd be no need for a witness whatsoever. the intelligence of the system can serve as that witness. And we're working on getting that done on the background with some of the DEA administrator, like we just had on the other day on the phone with us, as well as other government agencies that are instrumental in that decision-making power.
Yeah, and to that point, one of the important points that we need to emphasize also is that this is not just real-time surveillance of the transactional integrity of this actual event, but one can go back and review because this is all recorded and stored in the cloud. So we hear from diversion officers, from directors of pharmacy, from law enforcement, that a diversion incident investigation can take weeks, if not months. This is as simple as literally going to the videotape and going back and looking at this to ensure that what is done is what the operator says they're actually doing. So we can shortcut the cost and time and expense having to do all of those investigations by doing this and having it accessible. And that's why we think we can convince all of the stakeholders and anybody else in this food chain that this becomes the witness in lieu of an organic warm body witness, because frankly, without any regulations and compliance around that, no one's doing it the right way. So this is forcing compliance.
Great. Yeah, thanks for that color. And talk to me a little about the types of investors you're talking to and why strategic investors are top of mind for you.
Yeah, sure. So, one of the things that, we have as an opportunity, obviously the friends and families where a lot of the early money came from, but because we see Midas really making a difference in the medical community overall, and this is not just about opioids, right? I want to stress there's all kinds of medication that gets diverted, from expensive cancer medications to, some of the new classes of medications, behavioral, et cetera, is that we want to make sure that our investment partner is looking at this with us, holistically, is looking at this with us, not just to hospitals, but is looking at us with what we're going to be doing with retail, with all of the different stakeholders from the ASCs, the SNFs, the long-term care, et cetera. And we also think that because there's such a big data play and a big data opportunity, is that the right ways to develop, to market that data, to share that data, to get that data into the hands of the stakeholders who have, told us they want it or are interested. That's where strategic is going to come in.
Yep. And one other point I'll add to that is from a strategic point of view, it just makes sense, right, from a co-development opportunity to make sure this works efficiently and both for us and the investor on their behalf. So we're excited about those opportunities.
Great. Let's pause for a second to let anybody who's on the line and wants to jump in or ask a question, just flag, post it in the chat if you don't mind. I know Cedars-Sinai and Atrium are going to be using the recording for this because they had a tech issue. Great. So no questions in it. I think you nailed it then. That's always a good sign. Talked a little bit about the timeline
Sure.
for the raise. When are you looking to close? Things like that. Yeah.
So we have a few institutional opportunities, already on the table, and so those, with the way they're going, it could, and we're, just to give a little transparency around that, we're already at the stage where we've opened up the data room. They're starting to take a look at this with us. We see that being probably a 6 to 8 week process. Obviously, if anybody new comes in, we have to look at what their flow is and what their process and their timing is. But what we would like to do in order to hit our goals to be piloting this sort of on the cusp of 2021, 2022, we only need about 5 months to finish the development of the software, to get traction. HCA, like we said, already committed to the pilot. So we'd like to close, no later than the summer, right? We have a couple of months now to do that. And we could start putting proceeds to use as we have been, right? We've done quite a significant amount of development, the IP filing, hitting the market the way that we have. But summer is really the goal, because that would get us piloting no later than, the beginning of 2022.
Great. Okay. So we're looking for summer close. Getting some indication already. Great.
That's exactly right. Yeah.
And Chris asks from UVM Health Ventures, is it okay if he shares this with his supply chain expert?
Yeah, I think that would be fine. One of the things, and it's a good question, and I want to stress, is that when you look at these slides and you sort of look at the way that I brought you through this, imagine this in a hospital or institutional pharmacy, and imagine with that supply chain expert what it would be like if that medication was being able to be accounted for on site, destroyed on site, with that recording, and how much that could potentially save in that reverse distribution process. So yeah, it's
yeah, both within the healthcare institutions and in the pharmacy world, we really look at this as a natural extension or conclusion or destination of the medication supply chain. So right now it gets to a certain point, and then all of those controls disappear. So we're looking at this as finishing the circle on that supply chain loop. So we now button all of that up and know where it all goes and make sure that it's done securely and creates a verifiable record of that transaction.
Yeah, this is the last mile. I call this the last mile technology, and all of our products and in our pipeline, it's all about the last mile. This more importantly, because it's addressing what happens to, even if you're doing an investigation, right? From if you're looking at diversion or you're doing supply chain management with return medications, you always have the drug and it lands at the pharmacy. Then they destroy it, but there's really no good accountability there that we want that's addressing it. So we're excited about what we're doing around that.
Great, thank you.
You're welcome.
Any other questions from the audience? And Dave, just to don't mean to put you on the spot, but I did invite you on the screen if you wanted to share anything in terms of how Fairview is looking at the space generally. We'll see if he takes our invite. Yeah, it looks like he's jumping on.
Yeah, we reached out to the team from a perspective. We've got our academic medical center surrounded by 12 other hospitals in the community setting, and I just reached out to them once I looked at what Midas was doing. I was ignorant of what we were doing internally with them, and we were using not the state of the art components to do this, and our leadership said, we'd be interested in seeing this. We probably should take a look at something like this. So we're scheduled to meet with their team with a demo. I believe it was next week or the week after. Just lining up. We're juggling vaccine schedules and stuff like that. They're leading that charge. But there's just a real interest in what we're doing with the wasting of the medication and what's happening with diversion. And it's something that's really important to all of us in that acute setting. So for us, it's deemed to be important by our pharmacy leadership, and they want to take a look at the technology to see what's out there. They just hadn't done that yet. So for us, it really looks promising. Just from the outside looking in, I can't ask an intelligent pharmacy question, so I have to leave it at that. But there's just an interest in senior leadership from that. So I hope that helps, Doug.
Great. Yeah, thank you, Dave.
To amplify what was just said, that we found talking to Fairview, talking to a number of other hospital systems whose logos are in that slide and a bunch of others, is that there's a terrible disequilibrium between the controls on the dispensing side and the lack of controls, or as Dave said, the lack of state of the art. I mean, it's ironic that you can spend millions and millions of dollars on Pyxis machines or Omnicell machines, but your wasting technology is purchasable in aisle 5 at a Home Depot. It just doesn't make any sense that that's where we've come, because there hasn't been a technology to fill that gap. And we believe that we are presenting both the data technology and the containment and destruction and verification technology to fill in that gap.
Yep. And one of the analogies that's been used in plenty of our phone calls is the BD Pyxises and the Omnicells of the world have created the washing machine, right? They're still hanging the clothes on the clothesline around the wasting process. What we are is that dryer that should be right next to them. And we're providing that data around that dryer and how sophisticated it can be. And we're excited about how that can work for everybody.
Great. Great. Well, thanks for jumping on, Dave.
Yep.
I'll close you out for now. Great. It looks like we have another question from Brant Heiss, PM of Memorial Care Ventures. He asks, do you have a marketing or customer-focused material that we can send out to send our respective healthcare systems?
Yeah, so that's a great question. We do have a short executive summary. There is and what we can do is get that over to you without the investor sort of part of it, but we're really then taking a look and understanding what the product is, the problem that it's trying to solve, and it's it's without all the numbers part of this, but absolutely we can get that to you offline.
Great. Great. Any other questions from the group? Let me check, because I know the Atrium team is really eager to check this out, and they had an issue with their firewall, so they'll be looking at the recording. But great. So I think we're good to close now. You guys did a great job, ran through a ton of information, and gave us a clear picture of where you're at, where you're going, and how the folks on this call and other strategics might be able to help you get there. So to the folks on the line, take a look at their emails. If you're interested, reach out directly, and they can help take the next step or figure out the next steps together. Before I close, any last words from you three gentlemen?
Yeah, I don't think so. I think we've covered all of it. We're really happy with where we are. We've accelerated our conversations with the institutional investors now that we're through 2020 and through COVID, and the hospitals are all speaking to us pretty aggressively about the pilot opportunities. And so matching that with the investment opportunities for this round is right where we want to be. So we do appreciate it.
No, and these would be incredible strategic partners. I mean, I see UVM Health, HSS, some of the others that are watching on video. We would love to be both development partners and to be investment partners with you. Obviously, I'd love to be in Hanover, in Vermont, and working up there. And my partners are in New York City, so HSS obviously means a lot to them. But these are A-list institutions as members of SVG, and we would love to do business with you.
Yeah, that's terrific. I think my partners have really summed it up. We're excited to be hosting this call and taking care of that blind spot in medication management. So we're excited about moving forward with anybody that's interested.
Great. Well, I want to thank you again from Midas Healthcare Solutions for spending some time with us and sharing this investment opportunity. Our folks will reach out directly. There might be a few other intros that we can create from folks who didn't have a chance to join. And this will be available as a recording for SVG members, so you can send it internally or reference it again as due diligence. So we hope this leads to productive conversations, and we thank you for joining another Junto Health Dealflow event.
Great. Thank you.
Thanks,
Thank you.
everyone.
Bye-bye.
Bye.
Bye-bye.